Hello, and welcome to the Eastern EMS Council's protocol updates for 2017. Exciting information coming to you live, well, barely live. Okay, I'm almost awake. One of your co-regional medical directors, Duane Siberski. All right, every 2 years, let's give you the background behind this. We will go through all the protocols and update them with relevant, research-based information so that we can provide the best care for our patients. We're going to go through today are the important changes to the protocols. So there's 3 sets of protocols that are out there, the BLS, intermediate ALS, and ALS protocols. So if you're a basic provider, an EMT, you need to review the BLS protocols and their changes and be ready for a test that will be put on through the Train PA website in the future. If you're an intermediate ALS provider, AEMT, then you are responsible to review the BLS and the AEMT protocols and their changes, and again, be ready for the test. If you're an ALS provider, that means paramedic, PHRN, pre-hospital physician, PA, or pre-hospital physician, you're responsible for all 3 sets, BLS, AEMT, and ALS protocols and their changes, and be ready for the test. So with that having been said, let's get into the changes. We'll start with the BLS protocols. Protocol 170, it's the Adult Pediatric Patient Destination Protocol, ground transport. What this gives you is information that is where patients can end up. The significant change to that protocol is that in the case of veterans, it is acceptable to transport a patient to a veterans hospital that has an emergency department if the facility meets the other requirements of the Department of Health and it is the patient's choice. With regard to STEMI, the capability of providing cardiothoracic or cardiovascular surgery is not relevant in considering which facility is appropriate as long as they are capable of providing cardiac catheter care. Stroke, what they're going to add in is the clause, the designation of acute stroke ready hospital. Now that is a hospital that is not currently deemed a primary stroke center or a comprehensive stroke center, but they have the capabilities to provide acute stroke care. And the choice of going to the facilities, your primary and comprehensive should be number 1, as long as you can transport the patient there in less than 45 minutes. If that is not the case, then you can go to an acute stroke ready hospital. Protocol 204, BLS, it's the Adult Pediatric Abuse and Neglect. Essentially, this protocol, all they did was change the term to elder. They added that term. 206, the BLS protocol, is a new protocol. It's the Adult and Pediatric Human Trafficking Protocol. I'm not going to go into the protocol. This is brand new. This is something that you need to sit down, grab a cup of coffee, read it, and learn it. It gives you information on not only how to deal with the patient who you suspect is part of is a victim of human trafficking, but also the people who may be the perpetrators of it, how to interface with them, questions to ask, more importantly, what not to do. BLS Protocol 228 is a new one also. It's the Adult and Pediatric Glucose Measurement, the use of a glucometer for EMTs. This is an all-new protocol also, something to sit down with, read through it, and learn it. This is a protocol that was written here in the region, tested here in the region, and is ready to go. In BLS Protocol 251, it's the Adult and Pediatric EKG Monitoring Preparation Assisting with ALS Providers. In other words, you as a BLS provider putting the EKG leads on the patient. We currently now have a picture that is shows the appropriate positioning of the EKG leads. 261 is the Adult and Pediatric Spinal Care Protocol. Now, the importance with this is we've moved away from allowing the patients to languish on the long boards for extended periods of time, showing the increased risk of pressure sores as a result of the hard spine boards versus the skin. So as we've moved to that research-based evidence, we've also learned that the patient should be transported on the litter's mattress with appropriate spinal precautions. Now, the important changes are that the patient is to be transported in a supine position unless they are having difficulty breathing. If they are having difficulty breathing, then the ambulance litter can be moved to a position of patient comfort so that they are not experiencing difficulty breathing. In addition to that protocol is they add the term backboard to the scoop and orthopedic stretcher nomenclature. BLS Protocol 702 is the Adult and Pediatric Altered Level of Consciousness Diabetic Emergency. This one is where the use of the glucometer fits in for the treatment of the patient. It lists the system requirements for this optional skill, and it also has, with regard to the patient with the altered level of consciousness, wording with regard to suspicion of an opioid overdose, and it refers you to the appropriate protocol for treatment of a suspected opioid overdose. And the verbiage also continues that addresses the optional use of the glucometer, and it addresses if the BLS agency meets all the criteria and carries a glucometer with all providers trained to use that. So it refers back to previous protocols that are new. BLS Protocol 706, the Adult and Pediatric Suspected Stroke. With the systems requirement changes, the verbiage that we're starting to hear, rather than a myriad of descriptive terms, we're going to go with the terminology of last seen well. So with the evaluation of the patient that you suspect has a stroke, you're not going to ask, when did the symptoms start? When did you find the patient? The goal is that everybody uses the same terminology of the patient was last seen well, and document that point. Also within the suspected stroke protocol is verbiage for the use of the glucometer, and also gets back to the transport of that patient, and it refers to transport to the closest appropriate certified primary stroke center or comprehensive stroke center. If the patient can arrive at that center within 45 minutes, otherwise transport to an acute stroke ready hospital if that facility can be reached within 45 minutes. All right, we know that everybody can't get to a hospital within 45 minutes. That's where the command physicians come in, and contact with medical command may change which destination hospital you go to, or more importantly, what mode of transportation. And that also is listed in the protocols. BLS Protocol 832, the poisoning, toxin exposure, and this is from any method, ingestion, inhalation, absorption, or injection. Here's where we get into naloxone dosing that addresses the 2 milligram intranasal pre-filled kits with the atomizer, but also it lists a newer commercially available nasal device that has 4 milligrams of naloxone. So it allows for anywhere from 2 to 4 milligrams of naloxone to be utilized in a pre-filled nasal atomizing device. If you're using a intramuscular injection device, it lists the dosing as 0.4 milligrams by that auto-injector. And the goal is that if respiratory effort is not normal after 5 minutes, the dose may be repeated once. Further, it delineates that if inadequate spontaneous ventilation after repeated doses is not achieved, bag valve mask ventilation, oxygenation, and transport to an appropriate facility is the appropriate care. Those were the BLS protocols and the significant changes. What we know is that you already know your protocols, don't you? Because we all sit up at night reading our protocols. Now, but if we're utilizing them on a daily basis, we know the protocols. So the important thing is to know the changes and how those changes are going to be incorporated into the new actions that you're going to use to treat your patients. Now, for the intermediate ALS protocols for the AEMTs. First protocol that has any changes, and that was going to be the protocol 4001I. That's going to be protocol 4001I for adult and pediatric airway management. What changes here is in the topic of extraglottic or alternate airway devices. It adds the iGel supraglottic airway to a list of approved devices. Those other approved devices being CombiTube and King LT airway. Protocol 4011I is the adult and pediatric allergic reaction. Doesn't change the management. All it does is change the nomenclature of the epinephrine dosing. So instead of listing epinephrine dose of 1 to 1,000 epi, they now list it as 1 milligram per milliliter epinephrine. In protocol 5001I, the adult and pediatric suspected acute coronary syndrome, we've listed the goal pulse oximetry as being in the range of 95 to 99%. What you will also find is throughout all the protocols, if it refers to a specific range for pulse oximetry, that will be consistent through all the protocols. So they will all have 95 to 99%. The other item that has changed is that this is the first protocol you'll see it in, is the aspirin dosing. Acute coronary syndrome suspected, everyone gets aspirin, 324 milligrams. 4 of the 81 milligram baby aspirins chew and swallow. Even if they took their aspirin earlier in the day, this way there's no question as to how long ago was it, how many did they take, how many do I need to add to it, how many, 4 minus 3. I don't want anybody having to do math, and that's how we looked at it. And realistically, an additional 324 milligrams of aspirin is not going to overdose anybody. If you have a backache, you can take 650 milligrams of aspirin. However, if you have an acute coronary syndrome, you took a baby aspirin in the morning, you're getting an additional 324 milligrams. The goal is to deactivate the platelets. For protocol 7002I, altered level of consciousness, here's where we address the issue of glucose and glucose administration for the hypoglycemic patient. It lists that you can utilize a 10% dextrose solution as long as 25 grams of dextrose is given IV. The goal there is to get away from utilizing D50, which is a highly concentrated hypertonic solution that is extremely sclerotic to the veins. And by administering the same amount of glucose, 25 grams, it allows for the varied delivery methods. It can be the D50 diluted with normal saline. It can be D25 in a pre-filled syringe. It can be D10 in pre-filled syringes. It can be D10 mini bags of 250 cc's. All have equivalent 25 grams of glucose. All appropriately treat the patient. Most importantly, in this day and age when we have drug shortages, if you can't get D25 but you can get D50, great. You just know that your delivery is 25 grams of dextrose. Also in that protocol, they make specific note to the amount of naloxone administered, either 2 milligrams intramuscular or intranasal, and the goal is adequate breathing. It lists that you can repeat the dosing, 2 milligrams intramuscular or intranasal, half dose in each nostril. Realistically, we know that there may be a septal perforation, so some may end up crossing over into the other nostril, but again, it can go intranasal. And the goal is to get the patient conscious and breathing, not walking. You know, acute reversal and withdrawal from the opioid is not the goal. The goal is breathing and conscious. Protocol 7005I is the adult and pediatric shock protocol. The only change there is they've added the term sepsis as a cause of the shock. 7006I is the adult and pediatric stroke, again with the similarity in goal pulse oximetry of 95 to 99%, and verbiage changes for our AEMTs and above, that we're looking for last known well with a time goal of less than 12 hours and a target to transport the patient to a primary stroke center or a comprehensive stroke center or an acute stroke-ready hospital in less than 45 minutes. The data with regard to large vessel occlusion and interarterial interventions by comprehensive centers has been shown out to 12 hours, and so the research is there supporting it, and we're going to start looking at transporting the patients to appropriate facilities. With the intermediate providers, those were all of the protocols that we had changes in. All your protocols were new to start. We've just modified them a bit. For ALS providers, starting with ALS Protocol 1000, the general protocol principle, the only change there is with regard to the epinephrine concentration from 1 to 1,000 into milligrams per milliliter concentration. Likewise with the 1 to 10,000 epinephrine, 0.1 milligram per milliliter dosing. And that will be consistent through all protocols that utilize the medication. In Protocol 3080, the adult and pediatric post-resuscitative care. Again, consistency with the target pulse oximetry of 95 to 99%. Specific wording to obtain a 12-lead EKG in the post-arrest care patient. Transmit that 12-lead EKG to the receiving facility or command facility as soon as possible. And if transmission is not possible, to give copies of all 12-lead EKGs to the emergency department physician receiving the patient. If the 12-lead EKG is identified by the provider as a STEMI, transport the patient to a STEMI center, contacting medical command as early as possible for the expected arrival of that STEMI patient. There's also sedation options listed in the post-resuscitative care with equivalent doses between the different medications and maximum doses for all of the medications. ALS Protocol 4001 is the adult and pediatric airway management. Here again, under alternate or rescue options for airways, it lists the iGel supraglottic airway, along with the King LT airway and the Combi tube. ALS Protocol 4002 is the adult sedation-assisted intubation, listing etomidate as 0.3 milligrams per kilo, either IV or IO, as a single dose to a maximum of 30 milligrams. So a patient is a weight-based dosing for etomidate, but the patient's body weight may be 250 kilos. There's still a maximum of 30 milligrams. It also specifically in that protocol lists the iGel as an airway option. And then after management for the airway, sedation options with doses and maximums. In ALS protocol 4032, the PEDS protocol for croup, stridor, and upper airway disease, it lists epinephrine, the 1 milligram per milliliter dosing, as 5 milliliters via nebulizer in the treatment of croup if they are not using the racemic epinephrine 2.25 milligrams dose. So it gives an option of either racemic epinephrine or the 1 milligram per milliliter concentration epinephrine. ALS protocol 5001, the adult suspected acute coronary syndrome. Again, the continuity of the pulse oximetry of 95 to 99% as a target. For pain management, it gives appropriate dosing for both fentanyl and morphine. It addresses the aspirin, as everybody is administered aspirin. And with that, again, no questions, treat the patient appropriately, and move to an appropriate center. In ALS protocol 5021 for pediatrics, the pediatric bradycardia, it lists the appropriate dosing of epinephrine, and also, as based on current literature, shows that there is no minimum dosing for atropine. So the previous teachings of low-dose atropine causing a bradycardia in smaller pediatric patients has been disproven. So weight-based appropriate dosing for bradycardia can include atropine for pediatrics. In ALS protocol 5023 for the adult wide complex tachycardia, an option for the management of the wide complex tachycardia that is irregular can include lidocaine 1.5 milligrams per kilo IV, but this is only after contacting medical command. In protocol 6003, adult and pediatric musculoskeletal trauma, in the mild to moderate pain category, you have an alternate medication treatment with acetaminophen, 650 milligrams orally, or for pediatrics, 15 milligrams per kilo to a maximum of 650 milligrams as a treatment for their musculoskeletal pain. There's also appropriate fentanyl and morphine dosing with repeat dosings and maximum treatment dosings. Protocol 7002, adult altered level of consciousness, again addresses appropriate naloxone dosing and appropriate dextrose dosing. In 7002 pediatric, it also addresses naloxone dosing, but also gives a maximum with the logic behind it that if you are treating a pediatric patient with an altered level of consciousness and repeat multiple doses of naloxone having no effect, then there may be another treatment option that should be examined and explored for the treatment of that patient, because there is only so much that can be done with naloxone, and if it is ineffective, then an opioid as a cause of the altered level of consciousness may not be the most likely diagnosis. Also with pediatric, they again address the appropriate dextrose dosing and concentrations. In ALS protocol 7005, in adult and pediatric shock and sepsis, specific, there is listing of hydrocortisone dosing and route to appropriately address patients with congenital adrenal hyperplasia. Generally with these patients who have congenital adrenal hyperplasia, they already have their hydrocortisone at home. They may have already been administered the hydrocortisone prior to your arrival. However, in the case that the patient has not received their hydrocortisone prior to your arrival, you are then able to administer it, and it gives the appropriate dosing and route. It also addresses the management of shock and sepsis and blood pressure management with push dose epi, appropriate mixing of the medication, and dosing of the medication. IALS Protocol 7006, adult stroke. It's continuity again with the target pulse oximetry of 95 to 99%. Also the same verbiage of last known well. And in the verbiage also with regard to the symptom onset of less than 12 hours. And there's verbiage with regard to destination in the patients that have symptoms of 3 hours or less as to where they need to go. Primary stroke center, comprehensive stroke center, or acute stroke ready hospital if the first two cannot be arrived at within 45 minutes. Race scoring is also listed as an optional patient evaluation tool in the patients in the 3 to 12 hour symptom range with a race score greater than 5. Contacting medical command for destination choice is in the protocol. IALS Protocol 8002, all new excited delirium. No, not all new excited delirium. Excited delirium has been there. We now have a new protocol for excited delirium. It allows for 2 EMS providers, with at least one of the providers being an ALS provider above the AEMT level who has completed training with ketamine for the treatment of excited delirium. All right, as you read through that new protocol, you'll see that only one provider has to be ALS. They have to be trained to use the medication. The other provider could be an ALS provider. They could be an intermediate provider. They could be a basic provider, as long as that other provider is an EMS provider. IALS Protocol 8081, adult cyanide compound exposure, gives the option for the use of hydroxycobalamin in the treatment of a suspected cyanide exposure. That's all of them. Not a lot of laughter in there, but I got them all.